Hi everyone, I'm Rosa and I'm part of the Fertility Network team. Thanks for joining us for our webinar all about HSGs. Thanks to our corporate partner Gerbe, who've made this fab introduction for us and helped us organise this webinar. A massive thanks to Professor Anne Hemingway. Anne has personally undertaken and supervised over 12,000 HSG procedures, so can certainly speak with great expertise on the subject. She's published over 80 peer-reviewed articles, 30 book chapters, and delivered numerous lectures nationally and internationally. So we're very lucky to have her here with us today. Like many women going through fertility treatment, I've experienced a HSG and all the questions that come with having one. So I'm sure many of you have questions that will be answered by Anne, and if not, feel free to drop us a question in the chat box and we'll see if we can get through some of them at the end of the webinar. So Anne, thank you so much for joining us. I'll be here in the background, but I'm going to turn off my camera during your presentation. So over to you, Anne.
Thank you. Thank you very much, Rosa. And thank you for your kind introduction. Welcome, everybody. I hope you're all staying well in this rather strange and difficult time. So Rosa's introduced me just to say that I'm a radiologist at Hammersmith Hospital, part of Imperial College Healthcare Trust. I've been doing HSG since 1996, and as she said, I've done a few thousand. So I'm speaking from my experience of undertaking HSGs. I was fortunate to be trained how to do them by the great Professor Lord Robert Winston, and so I thank him for all the advice and tips he gave me when I started doing them. So just to go to conflict of interest, I am an advisory consultant to Gerbe. So what I'm going to do, I've put up here some of the common questions I'm asked by ladies who come for their HSG. And hopefully we'll cover a lot of them as we go through. And as Rosa's already said, if I don't cover a question, we'll see if we can sort that at the end. So things I'm often asked: why am I having this test? Will it hurt? How long will it take? Are there alternatives? Are the x-rays harmful? Will it help me to get pregnant? What will it show? Are there any side effects? When will I get the results? And how soon after the test can I have intercourse? So those are just some of the questions, and we'll go through. And I am going to put lots of pictures up, and I'll explain them on each slide as we go through. And you'll see pictures of what an HSG looks like flashing up, but I'll explain them. So what's the scope? What am I going to cover then? So a bit of background and context, a bit of anatomy, because it's always useful to know what it is we're looking at, what normally happens in a fertility workup and where the HSG fits into that, why is it requested, quite a lot about the actual procedure, how I do it and how my team do the HSGs, what are we looking for, what are the side effects, and what do we believe in our unit are the keys to success? That is, somebody where we have allowed a woman to have this test in the best way possible and come out with the answers that are required. A bit of context is really important. So you'll probably, many of you are so well informed, you'll know that infertility is defined by the World Health Organization as a disease of the reproductive system defined by the failure to conceive a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. And the context is how many people this affects. Worldwide, it's about 15% of couples. That's nearly 50 million couples. More in the developing world than in the developed world. But in the UK, that's about 3.5 million couples. So it's a large number of people. What are the causes of infertility? Well, this comes from NICE, the National Institute of Clinical Excellence. And you'll see that in about 25% of people, no cause is found, it's unexplained. And that can be quite frustrating for people not to know why they're not getting pregnant. But I'll talk a little bit more about that towards the end. In about another 25% of people, women, it may be related to ovulation disorders. In about 20%, it's tubal damage. Uterine factors, that's the womb, in about 10%, and then in the male partner, about 30%. But what's really important is that actually you might find a contributory factor in both partners in about 40% of couples. So that's why we investigate both partners when they're coming through for investigation. Talk a little bit about the fertility work and a bit about anatomy, so you can sort of try and imagine the what we're looking at when we do the HSG. When you first present to your GP or the fertility clinic, they're going to take a full medical history and do a physical exam. You'll have a range of blood tests, lots of hormone tests and various other things, but you'll have lots of blood tests, and they will almost certainly do a chlamydia test just to check you've not had chlamydia in the past. You'll have an ultrasound of the ovaries and the womb, the uterus, and then potentially a test of tubal patency. And there's 3 of those. I'll mention that, come back to that. And your partner will have a semen analysis. Let's just look at the anatomy for a minute. And if we look over here, you can see this is just a schematic diagram. This is your hips here, your hip bones here. And sitting down here at the bottom of your tummy is the womb. It's about the size of a pear. And you have the vagina here, the cervix, the womb, and then the fallopian tubes out to the ovaries out here, which are about the size of a strawberry. And the important to remember that the womb is a very muscular organ, and all of this paler pink is the thick muscle of the womb. So when you have an ultrasound scan, which you will all have either with jelly on the tummy or transvaginal ultrasound when they put the probe up through the vagina to look at your womb and ovaries, they will look at this, and they will look at this muscular wall. And here's an ultrasound here. This one has been done through the tummy. This is the bladder with some urine in it. This is the womb here. And this thick part here is the muscle, very thick. And this little white line down the middle is what we call the uterine cavity, this bit here. So it's a very tiny part. Most of the womb is muscle. And then the fallopian tubes that come off are also very tiny. And then the ovaries here, they will also look at. Here's a scan of an ovary. This is done transvaginally. And these are the developing follicles around the edge. So you will all have ultrasounds of your womb and ovaries. And then you may have a test of tubal patency. And there's 3 of those. There's the HSG, which I'm going to talk mostly about. Then there's the other thing, which a lot of you may have had or been asked about, which is HSGs, which stands for hysterosalpingography contrast sonography. Hystero, whenever you see the word hystero, that means womb. Salpingo means tube. So hysterosalpingogram means womb tube picture. So it's a picture of the womb and the tubes. And hystero contrast sonography, sono is when you have an ultrasound, that's sonography. So that's the same thing, looking at the womb and tubes, but using ultrasound. And then, of course, there's a laparoscopy, which is actually an operation. The HSG and HSGs are done as outpatients with no sedation, no anaesthetic. But a laparoscopy is done under general anaesthetic, usually is a day case. And that's actually an operation when they put a little camera through by a little nick by your belly button and another one up through the vagina and look at the womb and the ovaries and the surrounding structures. And then your partner will have a semen analysis. So that's the sort of general workup. Well, why is an HSG requested, and why are you having this test? Well, there's lots and lots of reasons. The most common reason is for subfertility. Somebody who's not either been able to get pregnant ever, that's called primary subfertility, or secondary subfertility. That's when somebody has been pregnant and maybe had a baby, but can't get pregnant again, or has got pregnant and sadly hasn't been able to continue with that pregnancy. So that's the commonest reason, but we also do HSGs in ladies who are suffering recurrent miscarriage, sadly. We also will do them in people who may have had an operation to correct some things. So they may have had a fibroid removed, that's called a myomectomy. They may have had some scar tissue treated. They may have had a number of what we call ERPCs or DNCs, and we're just wanting to check what the womb looks like. We may do it prior to a new round of IVF, particularly if the patient's had a problem with the last pregnancy, or they may have had a cesarean section, and the fertility team just want to make sure everything's okay before they start again. We do look at ladies who have had recurrent failure of implantation during assisted reproduction. We do them in ladies who want to be a surrogate for somebody. We do them as well, not so much recently, but we used to do quite a lot in people who'd been sterilised and were looking to have their sterilisation reversed to see if they could conceive naturally again. And we do it prior to something called fallopian tube recanalization. And again, I will mention that at the end, which is quite an exciting procedure. Of course, there are times when we don't do them. We obviously don't do them if somebody is pregnant, and we take great care before we start an HSG to make sure somebody actually hasn't conceived while they've been waiting. It does happen, and we love it if we do a pregnancy test on the room and we can say go home. It has happened to me through my career, and it's a great moment. It's lovely, but we do a lot of things to try and make sure we never do an HSG when somebody is pregnant. We would never do it if somebody had active infection. If you're bleeding at the time, immediately before your next period is due to start, or if you've had surgery to the womb or in that area in the last 6 weeks. And we don't do it because there's an increased risk of infection if we do it at those times. And if the contrast's not going where we want it to go, something we call intravasation. And also we might not get the right answer, and that's really important. We must not, so we don't do it in those situations. And we don't do it if you're allergic to contrast or you're allergic to iodine, or if you've got what we call uncontrolled thyroid disease, if you've got an overactive thyroid gland and it hasn't yet been brought under control. Once it's all under control, that's different, but we would wait until that has settled down. So I'm going to put this up now because I think I want to see that you can see that we sort of emphasize bits of it all the time as we go through, and then re-emphasize it at the end. The key to success for me that runs through all of this is communication, is actually communication with the people that refer you, with your partner, and the staff around, and then with the result at the end. Are you given a patient information leaflet? We need to provide an environment that's warm and comfortable and private. We need to listen to you and explain things to you and your partner if you want your partner present. For the chat bit at the beginning, give you time for questions, acknowledge your anxiety, and I'll talk a bit more about that. Provide experienced operators, and there's lots of evidence to say that female operators seem to come out better than men when they've done a few studies in the literature. Not always. Some of the male operators are phenomenally gentle and empathetic. Take your time, and if really important, have a close working relationship with the people who've referred you for the test. Really important. So what happens? Well, prior to you actually coming for your HSG, I as a radiologist will get a referral. I will get a form with your name, all your details from the person who's sending you, telling me all about why they want it. What's the question they're asking? Because they've taken the history and they know quite a bit about you. And when they send me the form, they should also give you an information leaflet arranging your HSG. This is ours, Imperial, and that gives you a lot of advice a little bit about what it is, what happens on the day, how you book the test, what you should do, etc. But that gives you a bit of background. And then when you come to book the test, that's also very important. We need to have people who you're going to be talking about your periods, and you're going to be asked when have you had sexual intercourse, so it needs to be discreet. And the staff that book it need to understand about the menstrual cycle so that they can advise you when it's safe to book the test. We in our department ask all our ladies to have no sexual intercourse at all, not even protected sexual intercourse, from the first day of that period until they've had the HSG done. And if you don't have regular periods, if you have very irregular periods or no periods at all, then we ask you not to have intercourse for at least 2 weeks, because that gives enough time, should a pregnancy have occurred, for the pregnancy test to become positive. And then we do a pregnancy test on all of our ladies on the day of the HSG. So that's belt and braces. So if you've not had sexual intercourse for at least 14 from the period, or 14 days if you've not had periods, and a pregnancy test, then the chances of doing an HSG with somebody pregnant are extremely low. But we do the belt and braces, and we have indeed had ladies who've turned up, not had intercourse since the last bleed, which they thought was a period, but we've had a positive pregnancy test. And that's because they conceived in the previous cycle, and in fact that wasn't a real period they've just had, it was a very early breakthrough bleed. And we will book the case usually from about day 5 of your cycle up to about day 14. So you've stopped bleeding and up to about ovulation. We can go up to day 21 if we need to. Some ladies have a much longer cycle. So it's a bit flexible, and that's why we need knowledgeable booking staff. On the day, And I start off with have breakfast. So many ladies arrive. I felt too anxious. I didn't have anything to eat. Now, if you've not had anything to eat, as my family would say, you feel anxious, hungry and anxious. You need to have something before you come. Well, if it's a slice of toast or a banana or whatever, believe me, it does make a difference. You've got some blood sugar going around and you feel a little bit better. When you arrive, you will go to the reception desk and check in. They will check all your details, your name, etc. If you are still bleeding on the day of the HSG, ring in and rebook it, because we don't want you to come all the way and then send you home. You may be able to book it for later the same week, but just remember, no more intercourse till you've had it. Check in. You'll then be collected from reception and taken to change. You can keep your top things on just into a gown to cover you over, and provide your urine sample for the pregnancy test. And then you'll be taken into the X-ray room. When you get there, and I'll show you a picture of an X-ray room, for many of you, it'll be the first time you've ever been into a hospital, let alone an X-ray room, and it can feel a bit overwhelming. So I'll explain a bit about that. There'll probably be 2 or 3 people in there. There'll be the doctor or the gynecologist who's going to do the actual test, a nurse who's going to help them with getting the bits and pieces ready that they might use, and the radiographer, who's the person who operates the equipment and actually helps take the pictures. They'll all introduce themselves so you know who they are. In our unit, we then sit you down, and for this bit, your partner can be in the room, and if you want them to, and we chat. We check we've got the right person, first of all. Really important. We check your name, your date of birth, and make sure you are the person we're expecting to be there. We check about your period. Have you not had intercourse? We check a bit of history. Have you ever been pregnant? Yes or no? What was the outcome? Have you had any operations? Have you had previous fertility treatment? 2 reasons for that. One is we need that information so that we tailor the test appropriately. But we also, this isn't a kind of conveyor belt. We want to know a bit about you and be able to have some empathy with why you're there. And then one of the important questions on this, we always ask our patients, do you have smears, and how are they? How do you find them? Because some people find smears difficult for lots of reasons, and please tell us if that's the case. And also some people find intercourse tricky. Tell us, because we want to again adjust our procedure and tailor our procedure to help you through the HSG. But if we don't know, then we're working in a bit of ignorance. So do feel free to explain that to the person. We will explain the procedure in detail to you, give you time for questions and answers. And if you're happy with everything at that point, we ask you to give your consent, which we take. I'll get you to just sign the back of the form. We check the pregnancy test that we've done, and if that's negative, then we carry on. And in our unit, all our ladies are given a one-off dose of antibiotics as well, and I'll explain that. And as part of the explanation, we may well show you a diagram like this, which just shows you, again, similar to that picture I showed at the beginning of the womb, and just how we will put a very fine tube into the neck of the womb here to put the fluid through. And I'll talk a bit more about that, the actual procedure now. So I talked a bit about 2 scary pictures here, one of the room and one of speculums. But this is an X-ray room, and I'm putting this up because, as I say, for many of you won't have been in one before. Just imagine it's a bed and a giant camera. That's what you're going into. Obviously, it's a more complex system than that, but that's fundamentally what it is. An HSG is a clean procedure, aseptic, and we have to wear a lead apron. Those of us that are in the room all the time, because we don't want to be getting x-rays all the time. You only get them once, but we're getting them all day. So we wear a lead apron to stop us getting the x-rays all the time. And we wear a gown, gloves, sterile gloves, and a mask. And now, because of COVID, it's almost certain that you will be asked to wear a mask as well, certainly for the immediate future if you come for an HSG, which is going to slightly limit communication, but not completely. Don't worry, we communicate a lot with our eyes and we can still speak to each other. We will then get you to lie on this x-ray table here on your back, and we get you to bend your knees, keep your heels together and open your knees out. Some units will use stirrups. We don't. I never have, and I think, but places vary, but we don't. We will then cover you over with a sterile towel so that you don't feel sort of completely exposed to the world. And at this point, I put in here communication, distraction, relaxation, and I've put a Margaret. Now, Margaret was our healthcare assistant who just retired, but absolutely, I attribute our success with HSGs a lot to her. Phenomenally useful. She would be standing next to you at the top, chatting to you, helping you with breathing techniques, relaxation while we do the whole test, nattering. She could manage to get somebody's life history out of them in 5 minutes, but always at the end, people would say, oh, Margaret was wonderful. She just kept my mind off what was going on. And that's really important. And again, it's part of the communication. We also often have music playing. I've had ladies say, do you mind if I listen to my music myself? Not at all. Whatever helps relaxation. Then the next bit, and you will see I've got this in bold in capitals. We put in a speculum. Now, if you've had an unfortunate experience in the past, you naturally are going to tense up at this point. You may not have had, they may be a breeze for you. Fantastic. All women, we all come in different shapes and sizes. So fortunately, we have speculums in different shapes and sizes. If you've ever been told that somebody's found one works best for you, then tell us that as well, if you know, so that we would start with that. They start from tiny ones down here, which are called virginal speculums. They're for people who, and some people are very small people. And there are, sometimes we need to use what's called the Winterton, which is a long, thin one. And actually people go, oh my goodness, but it's actually very gentle. And I personally prefer metal speculums. They're used once and discarded. I find them easier to use, smoother to use than plastic ones, but everybody will be different and people will have different preferences. And that's just what works best for me. But the most important thing is that when we put it in slowly and gently. More haste, less speed. You know, don't rush at this, and give it time. We often find that for everybody, there's a little bit of resistance just at the beginning. And at that point, and that's where the Margaret helps, breathing helps. Big breath in, hold your breath. And as you breathe out, let it out really slowly, as if you're breathing out through a straw, really, really slowly. And actually, at that moment, your muscles relax. And I'm just gently bringing gentle pressure. You just feel the thing gently slip in. So that can be really helpful, just some gentle breathing techniques. If it's hurting, ask them just to wait and stop a minute and just get your breath back and do it again gently. We don't need to rush this. And you can say, that hurts, can you just go slowly, please? Once we've got it in, we open it and we look at the neck of the womb called the cervix, and we assess that to see what bit of kit we're going to use to put the fluid into the womb. Now, we then choose which bit of kit we're going to use. And again, because lots of women are different shapes, different sizes, we have to have lots of different kit. And it can be something like, this is a little suction cup that snugs over the cervix. This one over here is a little balloon. And that's the one we most commonly use. Just a tiny little bit of the balloon at the end goes into the neck of the womb. This one is a lovely, very floppy, soft tip catheter, which can snug in and just blocks it off using this very soft rubber here. Or some people use these metal ones here. So this one and this one are the ones we use most commonly in our practice. And then having got that in, and again, we've done that gently, we then put the fluid in that's going to show up on the X-ray screens, and it's called contrast. It's not a dye. It doesn't change colour. We can just see it because it's got iodine in it, and we can see it on X-rays. And there are two types of fluid. There's a water-soluble contrast, which we've been using for a long time. And then there's an oil-soluble contrast, which some of you may have heard about. It's having a bit of a renaissance. In fact, it was the first contrast ever used back in the 1920s. And then it sort of dipped out for lots of reasons, out of fashion, but it's come back. And I'm going to say a little bit more about that at the end. So we would choose which of the two we're going to use. And then we will just very gently, and again, really important, put this into the womb and the tubes really, really slowly and gently. The reason we do it slowly and gently is because the womb, if you put something into the middle of the womb, its natural reaction is to want to push it back out again. So when you have a period, the womb's natural reaction is to push push the blood out. So if we put fluid in and we put it in too quickly, the womb says, oh, there's something in there, I'm going to push it out. And that's what can hurt. So if we can actually fool it and put it in really slowly and really gently, you don't get that sudden surge of discomfort. And the problem is, if you get a bit of discomfort, then the tubes say, I don't like this either, and they go into spasm and we can't feel them. So we want to really do this slowly and gently, and we can use lots of tricks to try and help the fluid go where we want it to, but still keeping very gentle fluid as we put it in. We watch what we're doing all the time on something called a fluoroscope, and that's some x-rays, which we do very intermittently, very low dose. We are obliged by law to keep the dose of x-rays as low as is practically possible to get the answer we need. And we watch it on a TV screen. And in fact, you can watch it too, which is quite nice. Some ladies like to watch it, some don't. But you can actually watch the fluid as well. We will actually take some pictures, like these ones down at the bottom here, which we keep for your record. We may move the x-ray equipment around a bit so we can see everything as we need to. We may tip the table, particularly putting your head down a little bit, letting gravity take the fluid through the tubes. We might roll you, tip you again, because gravity is great for allowing the fluid to go where we want it to. The other things that help are coughing and laughter. And people always say, yeah, don't be daft. How can anybody laugh when they're having an HSG? Believe me, we do have a lot of laughter in our room. We just do. And we get people to just, talk about anything and everything. And the minute you tell somebody not to laugh, they will often laugh. And amazingly, you see the fluid just pop through the tubes. The other thing that is helpful, as I say, is music and relaxed atmosphere. But patience as well. Sometimes we just stop everything we're doing, stop screening, stop injecting, and just wait and chat for 3 or 4 minutes. Then look again, and the fluid has quietly worked its way through the tubes. So you're getting the message here. It's slow and it's gentle, and be patient. The whole thing usually takes 10 to 20 minutes, sometimes less, occasionally a bit more if there's a tricky part of it, but usually about 10 to 20 minutes. So what are we looking for? Well, we're looking at all parts of that system. So what we have up here, we look at the cervix, and I've put size, position and number, and I'll explain the number bit to you. And we're looking at the uterine cavity of the womb, and we're looking at the shape and the size, and we're looking to see if there's anything in the womb because that's the environment that a potential pregnancy is going to grow in. So this is a normal HSG up here, and this person has read the textbook. It looks exactly like you will see it in the textbooks. Here's we're just holding onto our little tube or catheter here. This is the cervix, and this is the fluid, which shows up dark on x-rays. And you can just see the hips on this lady just at the sides over here, just to give you your orientation. And this is the womb. This is the middle bit. Remember that the muscle is all around here. We're not seeing the muscle. This is just the middle bit. And it's this beautiful triangle shape, completely uniform, very smooth edges, nothing in it. So this is the womb, and look, here's the fallopian tubes, and see how tiny they are. They're supposed to be. People often say, oh, that looks too small. No, they are. They're very small, which explains why they can so easily get blocked. So you've got these one tube coming off each side here. My little mouse had disappeared. Here we go. This tube coming off, very tiny here. Then it gets sort of fatter towards the end, and then the fluid comes out at the end here. This is called spill. And you can say the same on the side here. And this one over here, slightly disappearing under my little screen, but this womb is tipped over. And some of you have been told you've got an anteverted or a retroverted uterus. Perfectly normal, still the same lovely triangle shape. It just looks upside down. But the tube's coming off in just the same way. But then we're going to look very carefully at the womb, at the cavity here. And if you look at this one here, you can see in the middle here, there's a sort of lighter area. It's not that nice uniform dark. And that's a big polyp in that lady's womb. It could have been a fibroid. In her, it turned out to be a polyp. And so that's something that perfectly common finding. And people looking after you may choose just to remove that before you try to get pregnant. And both that lady's tubes were open. This is a lady who's got some scar tissue in her womb. She's had a lot of procedures done, and she's got some scar tissue. Again, really important to find, and that can be looked after and treated afterwards. Again, demonstrating both her tubes are open. If we look at this one here, we can see that a shape here is different. Instead of this nice smooth top, this has got a big dip in the top. And some of you may be told you've got a heart-shaped uterus, and this is what they mean. And that can be one of two things. It can mean it's got a sort of bit of muscle in here, or it was actually like two separate horns or a bit to the womb here. And you might be, if we see this on an HSG, it might be suggested that you go on and have an MRI or a 3D ultrasound just to see it a bit more clearly. And this is an MRI scan of this lady. You can see the muscle is this grey, darker grey, and this is the womb in the middle here. Now, I said at the beginning, two on cervix, the number. This is a lady who's got a double everything, double vagina, double cervix, double womb. And that's a very rare occurrence, but it's called a didelphys, because when all of us are made, when we are growing in our mother's womb and we were developing, the whole system starts off as two separate systems. And while we're developing, it all merges together. But every now and again it doesn't, and you end up with a double system like this, and so we end up doing an HSG on both sides of that system. But you'll read about that in I'm sure on lots of sites talk about. They're called congenital anomalies or Mullerian duct anomalies. We also look at the fallopian tubes. Really importantly, lots of people think an HSG is just to test a tubal patency. It's not. It's looking at the whole system. So we want to know, are the tubes patent? Are they open or are they blocked? We want to look at conditions. I'll show you what I mean by this. Salpingitis, or do they have a hydrosalpinx? We want to see what the spill looks like. And we want to see, can we reopen them? So this is a normal HSG. This is using oil, or the oily contrast. Here's the womb and here's the fluid coming through the tubes and spilling out the ends here like this. On this lady, however, you can see this tube is open, but there's nothing happening on this side. So this tube on the right is blocked because this lady's on her back. So this is the right of the patient here, and left over here. And this tube is blocked. This lady has this thing called salpingitis ischic nodosa, and if you look carefully, you can see these little bubbles of contrast on the tube just here, and that's because there's been some previous inflammation in that tube, and it's important to diagnose this because this lady would be at a slightly increased risk of an ectopic pregnancy, and you can imagine that a little embryo having been formed here could easily drop into one of those little pouches rather than get into the womb where it wants to be. This lady here has something called a hydrosalpinx. This is at the end of the tube, has become, again, because of some inflammation or maybe some infection, it's become blocked and dilated like a big sort of sac, and it's got some stagnant fluid in it. And that's important to diagnose because if that's left untreated or dealt with, that can have an impact on subsequent pregnancies and treatment. So these are all the sort of things we look at. And I mentioned earlier fallopian tube recanalization, and in some ladies, when we find the tubes are blocked, and this lady indeed, both of her tubes were blocked, the left and the right, and all of her other tests suggested that there was nothing else going on distant, there was nothing going on, she didn't have a hydrosalpinx on ultrasound, the womb looked good. My lovely colleague, Dr. Kashef, who's I call her the wizard with the wire, was able to actually pass a very fine tube up into the womb here and into this tube, and then she's opened up this tube here, and that's now open, and then pass the same tube, flipped it over into that one, and she's opened that tube up. So this lady arrived with 2 blocked tubes, went home with 2 open tubes, and she does a number of these cases, and it has a good outcome for quite a lot of the ladies, then able to attempt to conceive naturally. So that's fallopian tube recanalization. So after the procedure, well, the vast majority of patients go home or return to work immediately. I always tell people, go, please go. You've come and had something done, you've been anxious about it. Before you go rushing off to do whatever you're supposed to do next, go and give yourself some time. Go and sit down, maybe a bit more tricky now with all the social distancing, but go somewhere and have a cup of coffee and a muffin or a cake or something, and just give yourself a bit of time and space just to, get over it. We tend to think we've got to go rushing back to normal life. Don't, just treat yourself a little bit, I think. We explain the outcome. But tell them they'll get the full results in clinic. The HSG is only part of the picture. It's a jigsaw puzzle. And only the person who's referred you gets all the bits. They're the lucky person that gets the ultrasound and the bloods and your partner's semen analysis and everything, and can give you the whole answer. Take painkillers afterwards if you need them. I'll talk a bit more about pain in a minute. You might be given additional antibiotics. We will tell you to wear a pad or a panty liner because the fluid we put in will come out. There may be a bit of blood there, quite normal because we've been fiddling around. We tell you don't use a tampon because it just very slightly potentially increases the risk of infection. So just for that day, a pad or a panty liner. And we'll give you advice about intercourse. For most people, it's perfectly fine to have intercourse as soon as you want to after the test. Just a couple of times we may say, look, either use some form of contraception or don't until you've seen your doctor. That would be if we've found somebody's had a sterilisation procedure we've found has failed, so it hasn't worked and they're not wanting to get pregnant, we would say, explain that to them. Or if they've got this thing called Asherman syndrome, scar tissue, you want to get that treated before you try to get pregnant again. And we tell all of our patients, if you get a fever or you get an offensive discharge or you have pain that won't go away, contact the person who referred you or your local A&E department or your GP. Don't sit at home thinking, is this okay? Just get in touch with somebody. So we'll talk a bit about side effects and because it's an important thing. We talk about this when we're consenting our ladies. So pain, that's the biggest thing. They're patients where is it going to hurt? Let's be honest, it's not top of your bucket list. It's not what you want to be doing on that day. And it's not comfortable. Of course it isn't. But I do my utmost for it not to hurt. Let's be honest, it's not going to be comfortable, but we want to minimize the chances of it being painful. And I'll talk a bit more about pain in a minute and why some people may find it painful and what we can try and do to help that. Bleeding, I've mentioned, usually it's just a little spot or two of blood because we've been doing something and settles down during the course of that day. Just pad or the panty liner is enough. Infection, because we're putting a fluid in there that's not normally there. We want to be very careful. Everything we use is completely sterile, single use only, never used before, won't ever be used again. But on the advice of our microbiologists, we give all our ladies a single dose of antibiotics on the day. And then if we find something extra like a hydrosalpinx, we will give them a second antibiotic. The second antibiotic we often give is something called metronidazole or flagyl. And if we give that, we have to say, please remember, don't have any alcohol for 48 hours because you will feel very unwell. But mostly it's just the one antibiotic. We want to make sure the fluid only goes where we want it to go. We don't want it to go into the veins or the lymphatics. And I'll show, which is a picture down here of this. Normally, if it happens, when you don't have that nice smooth margin, you can see it getting in here. It just indicates that maybe there's been a bit of inflammation in the womb at that point, and we stop injecting any more fluid because we don't want it to go there. But that in itself has given us some information. I've told you how we avoid irradiating or x-raying somebody who's pregnant. And allergic reactions, again, we've asked you about allergies when we've taken the history. But they're very unusual. The one that I always remind ladies, and some of you know you're allergic to latex, please remember to tell us that because we want to use latex-free gloves. Normally the gloves we wear in the department have got latex in them, but if you have a latex allergy, let us know because we always have a supply of latex-free gloves, and everything else we use, all the other kits, latex-free, but we just want to be sure about that. Just talking about pain, because it's obviously a very big question for a lot of people. And why do some people find an HSG painful? And as I say, we do our utmost for it not to be. Well, what anxiety will contribute? And we understand that. You're coming for something, maybe the first time you're coming into a hospital, let alone an x-ray room, you're meeting strange people, you're having something done that is of huge importance to you. So you're going to be anxious. Anxiety increases discomfort and pain. That's very well known. And it's one of the reasons I say do have something to eat, because a low blood sugar will contribute to discomfort and pain and anxiety as well. If you think something's going to be painful, it is more likely to be painful. And many, many of you will have Googled Dr. Google will tell you lots of things. Unfortunately, lots of people put up bad things. Not many people put up, the vast majority of people don't put up that actually it wasn't too bad at all. Wasn't what I choose necessarily to be have done that yesterday morning, but it really wasn't as bad as I thought it was going to be. So the preconception of pain is very powerful. And if you Google HSGs on which this is a recent screenshot, you get over 4 million results. How do you sift those? How do you know which ones are scaremongering, which ones are genuine? You don't. So it is difficult. You may have had a previous poor smear experience. You may never have had a smear before. So that will can make it difficult. You may have something called vaginismus. It happens that actually you just find anything and you're very tight and it's hard and it's discomfort. Tell us if you know about that, because we will just go really slowly, try with a smaller speculum, take it really gently. And I always say to ladies, particularly if you've had bad experience before, you're in charge. This is your body. If it hurts, tell me to stop, and I will. Because we need to listen to what you're telling us. I've already explained, if we put the contrast in too quickly or forcefully, that will hurt. So we don't. We try and put it in really slowly. And there's a slightly controversial thing here, the advice about taking analgesia. Now, we don't advise our ladies on our information leaflet, although a lot of the clinicians do tell them to take some painkillers. If you tell somebody to take a painkiller, your brain says, oh, it's going to hurt. That's why I've been told to take a painkiller, which builds on this sort of preconception of pain. So I say, look, if you want to take a painkiller beforehand, feel free. That's entirely your choice. That I will leave entirely to the individual person. You know your own pain threshold better than I do. Some people seem to be able to tolerate huge amounts of discomfort without batting an eyelid. Other people find anything really uncomfortable, because we're all different. So you know yourself better. If you would feel more comfortable taking a painkiller beforehand, that's absolutely fine. How can we reduce it though? Well, communication is important. Empathy, explanation, experience of the people doing the test, a very slow, gentle technique, lots of distraction, taking your mind off it while we're doing it, and analgesia, as I said beforehand, painkillers, and afterwards if you need them. And the final question I want to come to, and the one that lots of people are now asking in a lot of the time, is, will having an HSG help me to get pregnant? Well, the HSG, first of all, is being done to see if there's any reason why you may not be getting pregnant. For example, do you have blocked fallopian tubes? And that's the prime reason you've been sent to make a diagnosis. And as you remember from the very beginning, in 25% of people, all the investigations, no cause is found, and we don't know. But that's an important group as we look at the rest of this slide. That's unexplained subfertility. Now, it's long been recognised from the days HSGs were first done that anecdotally some women get pregnant soon after having their HSG. I've had ladies come, they've had an HSG, they've been trying, one lovely lady, she'd been trying for 2 years, she came and had an HSG, got pregnant the month after, went on, had a baby. 2 years later, she reappeared. She said, I can't get pregnant again, can I have another HSG? Another HSG, got pregnant the month after. We don't totally understand why it happens. Is it just flushing the tubes? What is it doing? There's a lot of work going on to discover that. Now, as I mentioned before, there are two types of contrast, water and oily soluble, and is one better than the other? There was a theory that maybe the oily contrast was better than the water. So a couple of years ago, a study done in Holland was published where they looked at this in what's called a randomized study, where they compared one group of women had water soluble, one group had oil, and then they compared the outcome. Both of the groups, there was natural pregnancies occurred after the HSG, within the 6 months after the HSG. That answers another question about how long does the benefit of an HSG last. And they found that in women under 38 with unexplained subfertility, that's that important 25% group, 28% of the women who'd had water-soluble contrast and nearly 39% of the women who had oily-soluble contrast went on to have a baby. So that was really very important. So both work, but the oil seemed to be better than the water-soluble. And so on the back of that, the oily soluble contrast is sort of coming back into people's practice. And there are 2 large international studies have just started following up on that. One's to see when in your workup is the best time to have the HSG to maximise the chances of that. And the other group is to see if those results go into other areas, not just the women with unexplained subfertility. Is there a benefit of having an HSG with oily contrast in women with other things like problems with ovulation or mild tubal disease? So those are 2 things that are happening, and we won't have answers to those for a while, but it's an exciting time from that point of view. So hopefully, I'll go back now to my keys to success, that I've gone through a lot of those as to how I think those areas contribute to an HSG that is an okay experience for you and gives the answers that are required and helps you on your fertility journey. So that's the end of what I'm going to say, and maybe there's some questions you want to take me up on some of that, and thank you for listening. Is Rosa coming back? Yes. Hi, Rosa.
My dogs have been quiet the whole way through, and now they've just decided to start barking.
Yes, mine was scratching the floor a moment ago. You might have heard the scratch at the background.
I just ran downstairs now, and then just typically as you literally finished. Thank you so much, Anne. So we've got 4 questions that have come in, and one that's come in on the and now my partner's shouting hi as well. It's all going in my house. So we have one come in on the private chat, which is just curious. Is it not possible to see things like polyps, scar tissue on a vaginal ultrasound?
Yes, you can see. So on a straight vaginal ultrasound, you will get very good pictures of the womb. And yes, you may well see polyps. We often have patients come to us and it said, ultrasound suggestive of a polyp, please confirm. Yes, on an ordinary transvaginal ultrasound, you're not going to see if the tubes are open. You may see if there's a hydrosalpinx, but you're not going to be able to test tubal patency on a straight ultrasound. In some units, and I think a lot of units now are going on to do a hycosi, maybe at the same session or at a separate session. And that depends on local expertise, who's available to do what.
Okay.
But on a straight ultrasound, yes, you may well see the polyps. Scar tissue, not necessarily. It can be very fine, and HSG remains in many of the people who deal with scar tissue with Asherman syndrome. HSG remains the gold standard for picking up small areas of scar tissue.
Okay, that leads nicely on to this lady's next question, which is, when is a HSG indicated over a hycosi?
Well, that's again, I think that's personal expertise, that's local expertise. So if your local team has got phenomenal expertise in hycosi, then that's what they will do, that's what they're good at, that's what they understand. If your local team has got great expertise in HSG, they will go for that. So and some ladies end up having both, and there is a lot of work now because hycosi and something else called hyphosi, which is they use a foam rather than a contrast. So you may see both of those terms used. There's a lot of work going on comparing HSG and hyphosi or hycosi to see if they are strictly comparable. Well, the only thing I would say is with hycosi and hyphosi, you can see if the tubes are open. You sometimes can't necessarily say, are they both open? You can say at least one is open because you see the fluid pooling outside. And you can't necessarily see if you've got things like the little abnormalities in the tube itself. So it depends a bit on the history. It depends a bit on what else has been found. So if your teams suggest one or the other, it's because in your case they believe that's going to give them the information they need to proceed with your management and your treatment.
Okay, great, thanks. So I've got 4 questions and I've got some more coming in as well. I'm waiting for a laparoscopy and a HSG. I went back to my GP and have requested both after years of infertility. I've been told they'll do both on the same day. Would you expect both to be done under a general anaesthetic for a laparoscopy or completely separately?
They will do, in fact, what they will do, I don't think they will do an HSG as I just described it. They will do, what they're saying is, I suspect that they'll do what's called the lap and die. So a laparoscopy, which is under anaesthetic, and they will put they make a tiny little nick by your belly button, and they put a camera in, and they can look round, they can look at the ovaries, the outside of the womb, the outside of the tubes, and then at the same time they will put some fluid through, and it's normally a blue fluid actually on this occasion, that's why it's called lap and die, and they watch that come out of the tubes from the camera inside.
Okay.
So I think that's probably what they're suggesting they do with you, rather than the X-ray type of HSG. I might be wrong, but we wouldn't normally do both. Occasionally, very, very occasionally, people have done an X-ray during a laparoscopy, but that's quite unusual. So I think what they're saying to you, they're going to do a conventional lap and die, which is a very belt and braces procedure.
Yeah. Where does the contrast liquid spill into in a HSG?
Oh, okay. Yes, I didn't explain it. It comes out of the end of the fallopian tubes and it goes into what we call your peritoneal cavity. It goes around the ovaries, and in fact, you can sometimes see it almost more with the water one actually than the oil, going around the other things that are around there, which is things like your bowel and stuff like that. What happens to it? It gradually gets absorbed from the lining of the peritoneum. So some of it will come back out, as I've explained, the way it went in.
Yeah.
The bits that go through your tubes gradually get absorbed into through the lining of the peritoneum into your bloodstream, and you eventually pass out the iodine and the contrast when you wee later on, but you won't see anything, you won't notice anything, and that happens quite quickly. The oily contrast hangs around for a little bit longer because it's oil, like oil does hang around longer than water, you know that, but that's what happens to it. Okay. Yeah, it goes into the peritoneal cavity.
And what type of painkiller would you recommend?
Whatever suits you best. Most of us know which painkiller works for us. Paracetamol or ibuprofen, or a mixture of something like have a paracetamol aspirin combination or whatever. Most of us know what painkillers work for us, and so that would be the one. If somebody says to you, take ibuprofen, you think, well, actually that makes me feel a bit queasy, I prefer paracetamol. Take paracetamol. So take what works for you, basically, because then you'll feel reassured that it's going to carry on working for you.
Great. I'm not sure whether you'd be able to answer this one, but if you have a heart-shaped uterus, what are the chances of birth defects?
No, the heart-shaped uterus, if you get pregnant, that's not going to affect your baby having a birth defect. Won't be anything to do with the shape of the uterus. That's completely a sort of a separate thing. And many people with a heart-shaped uterus go on, and we don't even know people. Lots of people, the fortunate people who conceive easily and naturally, lots of them may have a heart-shaped uterus. We don't know about it because they've never had to have investigations. They've just got pregnant and had a baby. But it's one of the things that, we comment on because the shape is different, and it's something that when you're doing a report, you say this is the shape of the womb. But your baby, when you're fortunate to be pregnant, that's not going to affect the baby in terms of any birth defect the baby might have. Some of the very, very unusual shapes, which are very rare, can have an impact on how the pregnancy as a whole progresses, but then your doctors will manage that because they will know, and that's why it's important to know about it beforehand. The baby itself is a separate entity.
Yeah.
Does that make sense?
Yeah, completely. Yeah. I was told I had a hydrosalpinx on an ultrasound a couple of years ago, and I never had a HSG. Is this likely to change? Would a HSG be helpful, or does the hydrosalpinx mean my tube is definitely blocked?
Okay, if you've got a hydrosalpinx, there is some evidence that, and again, it varies. So this is kind of not 100%. So I'm just talking about sort of what is out there in the discussion world, that hydrosalpinges may affect implantation of embryos, because nobody totally understands why. And sometimes people with a hydrosalpinx, particularly if they've got two hydrosalpinges, you can't get pregnant. The tube is blocked at both ends, and you can't get pregnant. You have IVF. They actually suggest clipping those tubes so that there's no backwash of that stagnant fluid into the womb. But that varies, and each person is individual, so it's very difficult to give individual advice. An HSG might show the hydrosalpinx. Ultrasound done well is very good at picking up hydrosalpinges, and whether your team think that that is important in your fertility journey will depend on all the other factors involved. But certainly it's worth asking them. First of all, can they still see it on the ultrasound? Have you had an ultrasound recently? Because, you know, to see if it's the same or has it got bigger or anything else. And then are they planning to do anything about it? Perfectly legitimate questions to ask them.
Yeah. If you find out that the tubes are closed, can you reopen them at the same time as the HSG, or do you need to have a new procedure and reopen the tubes?
Right. By and large, at the moment, we tend to do it as a second procedure. The reason, for two reasons. One is that on our normal HSG list, we might have, I could have 8 ladies coming for an HSG in the morning, and to go on to the opening up the tubes takes a bit more time. We also, with those ladies, when we do it, because it is a bit more fiddly, that's the one occasion where we do actually give you some sedation, through a vein in your arm, so you know you feel you've sort of had a triple gin and tonic, really, just floating away. But for two reasons. One is because we don't want it to hurt while we're just opening them up, and secondly because actually that releases a bit of spasm in the muscle while we're opening it up. So we tend not to do it at the same time. We tend to bring you back, but because we've got the HSG, we bring you back in, give you some sedation and crack on, and Dr. Kashif just gets on and does it as a separate procedure usually. Some places, if they don't have a long list, might say at the time, are you okay for us to crack on? Normally though, I would say it would come back as, you'd come back as a second procedure.
Yeah. Final question. Can you request a HSG when you've had one a few years ago?
I think you can. It depends what the scenario is. If you've had one, and depends what that showed, and what's happened to you since. Excuse me. I think that's always very important. What's happened in the gap between the last one and this one? Have you had a baby? Have you not been able to get pregnant? Have you had a miscarriage or more, and you know, had a difficult time? Have you had any procedures? Certainly, if things have changed, if nothing else has happened, then the team may say, well, why? But then you can say, well, nothing's happened, so I can have another one just to see if anything has changed.
Yeah.
If you've had things done, then it's perfectly reasonable to say, can I have another one to see? But every story is different, so it depends a lot on why you had the first one, what's happened in the meantime.
Yeah, okay. Well, thanks so much, Anne. I just want to read a comment from one of our ladies, or sorry, one of our attendees. Absolutely excellent overview with the kindest, most sensitive presentation. Thank you. Which I think is really, really, it's right. And every time I've spoken to you, Anne, that's definitely what comes across. So those 12,000 people that have had a HSG with you have been very lucky, and I hope that we've made some of you feel a bit better about your HSGs and any other sort of bits you've got coming up. But this webinar will be available on our website, so if you want to re-watch it or anything, then just head over there. It won't be there for a few days, but we'll put it up as soon as possible. So yeah, unless you've got anything else you wanted to add, Anne.
No, I just want to say thank you very much for asking me to do it, and just wish all of your ladies good luck on their fertility journeys.
Yeah, no, that's great. Thanks again, Anne. Really, really appreciate your time.
No worries.
Everyone.
Take care.
Bye. Bye.